It is just a huge honor today. I've been wanting to podcast interview Dr. Todd Engel for probably since day one for 2 years. I finally got him today. Todd Engel is the founder of the Engel Institute, live patient implant continuing education recognized nationally and internationally. Dr. Engel is a diplomat at the International Congress of Oral Implantologists and maintains active membership status with the American College of Oral Implantology, Academy of Osseointegration, American Academy of Implant Dentistry, Academy of General Dentistry, the ADA, North Carolina Dental Society, California, on and on and on. Dr. Engel has extensive experience in dental implant rehabilitation, CT-guided surgical design, complex treatment planning, as well as full mouth rehab. Dr. Engel has hosted live radio, authored several articles, and has been featured keynote speaker both nationally and internationally on topics such as dental implants and restorative applications, digital radiography, CBCT, ridge augmentation, socket preservation, treatment of the dentulous patient, current dental materials, as well as comprehensive treatment planning on medically compromised patients. In 2002, Dr. Engel's lifelong dream of creating a learning institution where he could share, teach, and motivate other dental professionals was realized by the inception of the Engel Institute. The Institute has grown to now include 6 locations with faculty both national and international, and has trained over 8,500 dental professionals so far. I mean, you are an amazing man. I know so many dentists who went to your course, went hands-on. They talk about you on Dentaltown all the time. You are the man. And my question to you is, podcast listeners tend to be younger. They're not old and fat and bald like me at 54. They tend to be under 30. And they always say the same thing. They say, I just got out of school. We didn't place one implant. I don't know anything. And it just seems like so overwhelming. How do you go from, I graduated from dental school, never placed one, never saw one placed, just some didactic lectures on it, to actually placing an implant? How do you make that leap?
You know, at times it could be tough. First of all, I can't believe that you did that without taking a breath. That was amazing. Thank you, Howard, for having me on. I know that we've spoke about each other and known each other for quite some time. It's an honor to do this with you. So how do they do it? How do they make the jump? You know, it could be tough. Sometimes you have a comrade, you have a mother, a father, a sister, brother, someone else that graduated that can kind of hold your hand out of it. But, you know, it's really amazing because this is the fastest growing platform in all of dentistry. By far, it's growing faster than CT-guided surgery. It's growing faster than cone beams and all the technologies that's out there, because it's all surrounding implantology. And here you have these kids, as you say, coming out of school, wanting to get involved with this thing that's spinning so fast. Yet it has the biggest liability. We never did any of it in dental school, and it's scary. You know, I think that you gotta love it to be good at it. If you don't love it, there's a high failure rate. And I think you really need to. I think one of the things that I love most about what I do is I teach people a lot about what they shouldn't do. And I think that's really important. In fact, I think sometimes it's more important than learning what you should do. Because if you go out there and you approach something and you know what can hit you on the blind side, you become more educated. You walk the streets differently. So with implantology, I think everybody grows at a different rate. Coming out of school, there were things that I wouldn't do in a million years coming out of school that I do now, and I don't even think twice about, much like driving a car. So I think that the thing which we'll get into, the thing that's made it so successful for the Engel Institute is mimicking much like what we did in dental school. I mean, let's face it, you can't just work on one glass block and then go out and do endo. You can't work on one kid and then go do pedo. And it's really funny because we go out and now we want to take a weekend course or 2 courses and go get involved with implantology, watch our treatment plans just explode exponentially, like big ticket items. And what's really interesting is this is the most irreversible thing that we do, and it's dangerous. So the question is, what do we do? I think we can dabble in various forms of education, and we can pick and choose what we feel would be best for us. We all tick differently. But like I said, the thing that's made it great for the Engel Institute and something that I love is the fact that we've recreated something that's very, very similar to dental school. I also think that teachers, instructors have very different perspectives and reasons for teaching. But we'll get into all that, I'm sure.
Is it true that in dental school that those who can do and those who can't teach? That's what they used to say in our dental school 30 years ago.
It's pretty true. You know, what's really interesting is they always say the most successful dentists are the ones that are right in the middle of the class, because they have a really good combination of being able to speak well and also doing pretty good dentistry. And sometimes when you pitch towards the end, you tend to maybe lose some of that. But, you know, there's a lot of wonderful dental schools. There's a lot of wonderful students. Women in dentistry is booming, which I think is just so hip and so cool. I would love to actually have a female associate, and I've been looking for one. But, you know, dentistry is a great place, Howard. It really is. If you pick and choose ways to navigate through it and stay out of trouble. And I think one of the biggest things that's overlooked in dental school is not only how to run a business, which notoriously we know that, but it's how to speak to people. And that's something you can't always teach, right? You can't always teach. And so through my classes, what we do is we make sure that there are agreements in place with doctor and patient. Like, hey man, what is it that you expect from me? Can I tell you what I think I'm capable of delivering to you? And we're not all the same. There are people out in the world that are far more talented than I, Howard, right? And so I may not promise a patient something that those that are better than me may promise. And I think it's really important going into implant dentistry. And one of the things I talk about, no matter what stage I'm on, man, you've got to be disciplined. You've got to be disciplined. Sometimes it's hard. Sometimes someone walks in and is willing to lay 50 grand on the table for a new set of chompers. And you know what? It's a lot easier to sign the back of a check than the front of one.
You know, I posted yesterday on Dentaltown, successful people are not gifted. They just work hard, then succeed on purpose. If you want it, work for it. It's that simple. How hard is it to work for it to go from, I came out of school, never placed one, to where I can do the 80-20 world? And I want to preface it like this. You know, if you ask any general dentist in America, what % of your root canals fail? Every one of them will say, well, knock on wood. I've never had one fail. Yeah. And then you look at the United States data, and there's 4,000 endodontists that are full-time, and 2/3 of their practice is retreats. But now we're looking at insurance data, and they're crunching hundreds of millions of claims. And they say if an endodontist does a molar root canal, and they're defining a failure as extracted, they're not talking about the periapical radiolucid didn't heal. They're talking about the tooth is no longer in the head. If the endodontists do a first molar in 5 years, 5% of them are extracted. So that's a 1 in 20. And if a general dentist does it, 10% are extracted within 5 years. It's keeping the equal to. So the endodontist does everything right, and it's a 5% failure rate. The general dentist probably messes up and doesn't do everything quite right. They have a 10%. I imagine the endodontist failure rate is mostly the patient wagging the dentist's tail, because so many times I've told a patient, you know, I think this tooth is cracked. I think it needs to come out. No, just try to save it. And you're looking at this black line and this black crack, and Mrs. Cranston doesn't want to lose her molar. You know, sure. So I'm sure a lot of that is the misdiagnosis of a cracked tooth and the patient talking into it. But what is that the same with implants? I mean, if an oral surgeon or a periodontist placed it, would they, you know, the endodontists have a 5% 5-year failure rate. We have a 10% 5-year failure rate. Is this general dentist getting in over their head more than a root canal, less than a root canal? Is it treatment planning? How do you keep your success rate up high enough as opposed to send them to a periodontist or an oral surgeon?
Yeah, I totally appreciate the question. By gosh, it's loaded. It really is, because look, dentistry is one of those things where the sky's the limit on talent. You can go and you can work your rear end off, and like me, I stay up at least an hour a day and read and try to become better. You can go until tomorrow comes, and then guess what? You're one step closer to not knowing everything. So I think what's really interesting, coming to the endo implant comparison, it's a number of things. One, we don't talk about failure every time we do endo. Okay? We don't. I mean, when we talk about weighing out the option, and they say, should I remove the tooth or should I keep the tooth? How long might endo last? I would say that conversation about how long does an endo last is 1 out of 10 times, 1 out of 8 times, 1 out of 6 times, whatever. When you talk about implant dentistry to a patient, the number one thing that they're asking is, how long does this last? Right? And I think that there's a couple reasons. Number one, they're spending a heck of a lot of money when it's all said and done for one tooth. They're spending over $3,000 a tooth. And theoretically, in the patient's mind, once the implant fails, in their opinion, you don't really have another shot at it. If the implant didn't work, then I've got to go to a bridge, right? Which isn't always the case. But with endo's kind of like, it's almost like a primary tooth. You have one more shot. If the endo doesn't work, you can retreat it. And in worst case scenarios, you extract the tooth, and then you guess what? Then you go for the implant after that. So you're not at the edge of the world. You're not at the edge of the earth tipping over. So I would venture to say that there's a lot of endo that turns on the practitioner 10, 13 years down the road that we may never see, right? And we don't know why. In terms of the loaded question, I do about 8 things, Howard. I really do. I do about 8 things personally in my practice. I practice 2 days a week, and I pretty much teach the rest. And I work on those 8 things as hard as I can, because every day that I wake up, I still want to be better. And you know what's really interesting, in the great words of Steve Jobs, he said right before he died, he said, to become really successful is going to drive you crazy. He said, because to reach that success, for someone to actually put up with all of the crap that they have to go to get there, if you don't love it, you give up. So I think one of the first things you asked me was, are there different levels of this? Are there different levels of success, and how do you achieve that? And I could just say that, I've always told my kids, if you have an offer to eat with a rich man or a wise man, take the wise one. And I just feel that nothing beats knowledge. And you got to keep working at it, man. You have to keep going. And I think, what's really interesting is I think we all have different opinions of what we want our results to look like, right? For me, I'm very hard on myself. Each time I look at an x-ray or I look in the patient's mouth or I see them smile, is it level with their pupils? Is bone up to the collar? Does the tooth match? I'm really hard on myself. And I think that that's yet another variable: surgical skills, instrumentation, technique. You got DSOs out there now that are forcing you to work harder and faster. And maybe you can't always get the A result. Maybe a B or B minus result is good enough for 20 or 30 years. So there's just so many things. I've never claimed to be a supermarket. I'm a dairy. If you need some things, I'll carry a dozen things, and I'll carry them really well. And that's kind of what I share with my comrades. And when I talk about success of the Institute, it's not money. And it's not notoriety. It's watching what my peers do with their patients. We have over 300,000 implants being placed annually from alumni. Can you believe that?
That is amazing. You talk about DSOs pushing them harder. The last stats I saw that came out of Henry Schein was the DSO market is 12% of the dentists, but they're doing 20% of the dentistry.
Yeah, here's the thing.
That's production.
Sorry to cut you off. I've been one of the predominant Heartland implant trainers for quite a while, and I can tell you that the days of the daughter coming into dad's office, or the son coming into dad's office and trying to make a buck, Howard, it's really tough. I mean, how can you sell glue for $20, right? If the person that's at the DSO buys it for $3.50 and can sell it for $8, it's tough. It's really tough. But I think, it goes back to what I firmly believe in it, and that is that your patients are always going to want to find that talent. I really believe that. There's some kid in the back of some farm in Kentucky right now pitching that wants to get to the big leagues. There's some really cool restaurant that serves 14 people at a time that's tucked behind some newspaper building that has great food and survives because people know that they're there. And I think that if we are conscientious and take really good care of our patients, and we really perform what we're capable of doing, I think dentistry can be fantastic. I think the problem with the GPs in surgery that I see is that they get in over their head. And so I love this. I could talk about this, until next Friday. I'm very passionate about what I do. I wake up every single morning, regardless how many hours I slept, I'm ready to go again. And I love what I do. And I think that encourages you to want to be better. And I want to be better. I want to help my comrades be better.
What are these 8 things that you work on?
Well, they're all surgically related, so I do a lot of socket grafting. I think the GPs that aren't doing socket grafting should absolutely 100% start. We have a great class to help them if that's an interest. I do a lot of tissue grafting. I think that's incredibly important, something that we're actually anemic on coming out of dental school. And if you want to be involved in surgery and you want to have these exquisite or indistinguishable results, you better know how to deal with tissue. I obviously do a lot of extractions, and I do single implants all the way up to full mouth rehabs. But what I'm saying is that it's always those same things. And I remember, when I was younger and I was working on television, in between my gigs, I was a waiter, And the thing that I loved about waiting was it's always a new adventure. Yes, you're serving spaghetti, and yes, you're serving spaghetti, and the plate's always the same. But the patron's different, right? So even though I might do a single on you, I can do a single on Mary, and it's still exciting for me because it's a whole new gig, right? So I do those things, and I try to be better at them. I think one of the things that I've worked on a lot is what I call a good, better, best. I think as Americans, billions of dollars have gone into different ways that we think. And one of the things that we know for sure is that we like things in threes. That's why we tell jokes about the Catholic, the Jew, and the Protestant went to a bar, ... right? Or if you go into Starbucks, there's 3-size coffees, or Manny Mo and Jack, or Neapolitan ice cream. We like threes. And so when a patient comes in, one of the things that I talk about is good, better, best. Hey, Sally, I want to show you good, better, best, and I want you to tell me what works for you, right? What works for you? And, Howard, I think what I've learned over my 20 years of doing dentistry, and I love this industry. Do I have frustrations? Do I get angry patients? Of course, I think a lot of it is in the rebound, number one. But I think that as long as you're truthful and you try to become what my goal is, and I'm not there yet, an expert diagnostician. You see, an expert diagnostician. So the people in my class would be like, "What do you mean?" And what I mean is this: really get good at what you see. Like you were talking about, should I save the tooth? Does the endo work? Can I see the canal? Okay? Really get down and truthful with yourself and look at that x-ray or look at the mouth or look at all the data and say, do I know what I see? That's number one. Number two, Howard, I'm going to provide you with your options. Not what's good for me and what I do so I can bill you out. What you are capable of having done for you, Howard. That's number two. Being able to provide the patient with really good options. And then number three, which I think is one of the hardest parts of it all, is knowing if you're capable of doing it. You see? Knowing if you're capable of doing it. Because if a very, systemically challenged person comes into my office and I know that the person needs to be in the OR, to have surgery done, I'm gonna punt the case. Can I do it? I can do it. But is it right for me? It's not right for me. But the patient still deserves it, right? So that's pretty much it. I think that's my center of gravity, man.
When you say, knowing if you're capable of doing it, it seems like the dentist, there's 161,000 Americans who have a license to practice dentistry, whether they're general dentists, endodontists. I'm sorry, 165,000 general dentists, 211,000 total, including the specialists. But it seems like the dentists are divided in half. Half of them just like the pretty white and fluffy stuff, bonding, bleaching, veneers. They'll get into Invisalign, sleep apnea. Then the other half are the bloody barbarians. They like extractions and root canals and implants. And so many of these kids are afraid of going into implantology, but I see them doing extractions. What is a skill set that you can do surgically that you can look at and say, dude, if you could do that, if you can take one out, you can put one in. What would be a similar extraction skill level to place a root form?
Yeah, you know what's really interesting about what you said? I don't know if you're alluding to Gordon Christensen's article that he did several years ago, like almost 20 now. And he said, you know, what's really interesting is that GPs, if you ask them if they're placing implants, it's like, no way, no way, we don't want any of that. There's just way too much liability. And he also mentioned in the article, he said, but 40% of them are yanking out whizzies. He said, and they don't. So if you ask a GP who's in the audience, hey, you know, why is it? I love this. I'll always say, who here is pulling out wisdom teeth? And literally 70% of the hands will go up. And then I'll say, who's placing implants? And 1 out of 20 will go up. And what's really interesting is for some reason they think pulling the tooth out is safer. But there's plenty of studies that show that the lingual nerve is sitting right there at the occlusal plane of the third molar, and that's incredibly dangerous. So what's as easy as a root form? Howard, I can tell you that truly that when it's the right case that's chosen, I personally think it's easier than a composite. But I will tell you this, because if anyone's listening, I want to be clear about this, and I know people are. I'm not suggesting that you can learn how to do implants as fast as you can learn how to do a composite. What I'm trying to say is that once you have somewhat mastered the art of implantology, placing an implant is quite simple.
So I'm going to go through, you know, sapien is a complex animal, and I like to see, you know, when they're trying to make a decision, what do they get hung up on? I meet so many people in my lecture. They say, "Yeah, I want to start, but I know I need to pick the system first, and
Yeah.
because then you pick the system, that's a training. Is your training implant agnostic? Do you really need to know the system before you go to the training? And help these kids out. There's
Yeah.
175 companies selling dental implants, and it's an overwhelming decision. I was talking to a little young 26-year-old woman dentist yesterday. She's already gone to 7 different
Yeah.
company lectures,
Yeah.
and she just can't get her head around of where to start. And she thinks she has to start with choosing the system first, then
Yeah.
she'll get the training to place. What do you think about that decision
So,
making
so,
matrix?
so it's entirely incorrect. I will tell you this. When you go to drive a car, when you go to learn how to drive a car, you go to driver's ed, they're going to put you in something safe. You're going to drive a Honda or, you know, something very safe, very practical. I will bet you that 95% of the people that take their driver's ed training in that car do not buy that car. So the analogy that I'm giving you is this. I don't teach a manufactured implant company's implant course. I teach doctors how to place implants. So once you have the understanding of foundation, bone, tissue, blood supply, where are the nerves, where are the arteries, what are the angulations, how do you restore just the game of implant dentistry, you can give me a $40 implant, Howard, and I can be successful with it. You can give me a $440 implant and I can be successful. I'm telling you that I've done this long enough to know, after 17,000 plus personally placed between myself and my courses, I can tell you that you do not learn around a company. You do not learn around a kit. This is the language of implantology. It's the language of implantology. When you understand how bone grows, when you understand what patients present with challenges, when you understand how implants integrate, it doesn't matter which one it is. Conceptually, it's implant dentistry. I mean, look at Brannemark from way back when. Titanium's still integrating. He didn't place, you know, one of these implants coming in from overseas.
So I'm trying to go through their decision making. I think dentists suffer the most from paralysis by overanalysis. I
Yeah.
mean, Las Vegas doesn't. You know, we have an annual dental convention. We're having our 15th annual, April 19th and 21 in Caesars, and it's so hard to get a meeting space because they track and they say dentists don't gamble, engineers don't gamble. They're too smart to go to the table and throw all their money away. Another thing they're getting caught up on is, man, I got $350,000 student loans. Now you're telling me to buy a $100,000 CBCT. And it's not only that, but a lot of them say, okay, my first cell phone was a Motorola flip phone. I wouldn't have wanted to own that for 30 years because every 5 years you want to throw away your old cell phone and get a brand new. So I just got the iPhone 6 Plus, and this is
Yeah.
probably my third or fourth generation. If I buy a CBCT in 5 years, is it going to be a Motorola flip phone? Do I need to buy a CBCT? Talk about that, because that $100,000 decision,
Yeah.
especially something with could be obsolete in 5 years. Rant about that.
Well, first of all, I've waited 16 years for an invitation, I'll have you know. And I haven't been invited to your darn program in Vegas, and I'm still waiting. And you know what the interesting?
If you want to speak, you're
I hold
speaking.
no grudges, buddy.
It's what?
I hold no grudges, even after 16 years. Right. But let me mention something about Vegas, because I lectured in Vegas for 4 years every single month. Okay, every single month. I flew from East Coast, West Coast to Vegas, and I can tell you that it is true that the hotels do not rely on our money. For whatever reason, this is true. That's why the dental meetings typically take place during the week, because they won't give you the weekend time. To hell with them. We'll keep our money. We work hard for it, right? Right?
Yeah,
okay.
yeah.
So the second part that you were asking me about was, tell me.
If I buy a $100,000 CBCT, is it going to be like a Motorola flip phone in 5 years? And I'll be wanting the new iPhone?
So here's the thing. My first few thousand implants, I actually placed two-dimensionally. And I feel that that's led to most of the success with my courses, because I really had to learn where I was and what I was doing, right? In 2006, I became one of the beta testers for ICAT. Before that, you would not find cone beams anywhere. Were there problems? I'm sure. Were there implants placed that were malpositioned? I'm sure. Just like the speed laws. Things happen, and then changes are made. So what happened? Well, we got cone beam. Okay, so when we talk about today's cone beam versus cone beam in 7 years from now, will it flip up? Will it be a halo over the patient's head that we won't even need to walk them into a machine? Of course, that's all going to change. Will they be 35,000? I bet they will. But here's the thing. Whether you've placed one implant or 4,000 implants, you are considered a surgeon. And your number one objective is to keep a patient safe. And if a cone beam machine today will help you achieve that, then great. You only need a cone beam when you need a cone beam, Howard. Right? If everything comes out great, then you don't need a cone beam. But if something happens where it doesn't, and you find yourself in a court of law, then they're going to say, well, how did you decide to put this implant in where you did? You need some help. So do I think that every GP should run out and spend $100,000? Heck no. There's no way I would do that. In fact, anyone that would be listening, I would say, put it in your education first. You're way far away from needing that. Here's the deal. If you're worried about placing implants without a cone beam, then have your patients go down the street for $260, get a scan, and they'll email it to you in 15 minutes. Once you've done 15 or 20 and you say, you know what, I like this game, I'm getting better at it, I think I can do more if I had more technology, then sink in. I mean, it's the same thing with CEREC. CEREC is wonderful. It's incredible. I get guys all the time at my course that swear by it. It is a great machine. What are the new ones, 140 grand? Right?
Right.
They wouldn't think twice about dropping it on CEREC 5 or 6 or 7, nor should they, right? So once you find a value for that little thing, then you really don't consider the monthly payment. My recommendation is this. If you're going to place 6 to 7 implants every month, then you might want to look at a cone beam. Because right now...
6 or 7 a month? So critical mass, you're saying critical mass is it 1 a week? That's 50 a year. Is it 2 a week? That's 100 a year. What is critical mass to get competent? I mean, I wouldn't want to get, if I was going to get, prostate surgery, I wouldn't want it done by somebody who does 1 case every month. I'd rather do it, someone who does a couple cases a day.
Yeah, no, of course. And
what's critical mass? What's the number of critical mass?
So it's a lot of it's more about a rhythm. I can tell you that most of the averages coming out of the institute, and we stay in touch with these people, is typically about 46 to 48 a year. So 4 to 5 a month. I got guys coming out that are doing 150, and it's your tempo. I think that well, first of all, I completely concur with your with your analogy of getting surgery done by, someone who, does them all day long, and I completely understand. But when we're talking about a patient going into a general dentistry office and the patient's sitting there and going, "Hey doc, I trust you. You can do it. Come on." They're not really going to know whether they've done one or a million. I mean, critical masses. As it relates to cone beam, 4 to 6 a month. As it relates to creating a rhythm, I think that, if you can get 1 to 2 implants on the books per week, which I think is pretty easy, you tend to see them more when you understand them more. 1 to 2 a week can get you rocking.
Okay, I want to go back one question because I know my homies.
Yeah.
Give them a short list of implant companies just so they can get that out of their system. If they're going to pick a system, give them a short. Do you have like the most favorite? Do you have like 3 that are the same, 5, 6? Is there any help you can throw them their way on systems?
Well, I think I'm going to hedge a little, okay? Because I have one that
because you don't want to piss anybody off.
Well, it's not even about pissing them off. I just have one that I'm a one-man guy, so it's kind of like if I find something that works to the way I like it, I just stick with that one. I don't have 16 different implants.
Well, what is your one system that you're using?
I'm a Straumann guy.
Straumann. And Straumann's a monster. They bought Megagen out of Korea. They bought Neodent out of Brazil. They bought, what is it, MTI out of Israel.
They really are rocking. In fact, they're the #1 implant company in the world. But that doesn't mean that you have to do what I do or that you have to be a Straumann person. Listen, you might not have the luxury of working with a premium player. You just might not. You might have to go with a value price player. And guess what? There's a lot of good ones out there. There really are, Howard. I'd be lying if I said that there wouldn't.
But Straumann's a great choice. If you get Straumann, you're not going to go wrong.
Yeah, that's for sure. I mean,
well, that's good enough for if you're driving down the car right now, you got an answer. There's Straumann. Just go to the next. Okay, so the other thing that's confusing these young implantologists is they're pulling their easy wisdom teeth, maybe their soft tissue impactions, but full bonies are sent to an oral surgeon. They're talking to an oral surgeon at lunch, and when it gets to surgical guides, the oral surgeon is usually 50 or 60, he's an old fart like me, and he says, "I've placed a gazillion implants, and I've never used a surgical guide. It's like training wheels on a bicycle." And then the young girls going to the study clubs are all talking about surgical guides, and they're like, and so it's very confusing when every old oral surgeon says it's training wheels on a bicycle. You need to grow up, take off the training wheels, and learn to be a surgeon. So what's your view on that rant?
Well, it's really hard because you have a big paradigm shift right now, Howard. You have a generation that's kind of moving out, and you have a generation that's kind of in. And last year, for the first time in the U.S., we had more surgeries done by GPs than we did by surgeons, which is telling you something. I'm not suggesting that that's good or bad. I'm just saying it is. It's a number, right? And the problem is that the younger folks, let's say, up to 34 years old that are looking for help, that don't have someone sharing an office with them, they go to these meetings and they go to listen to the really brainiacs of the surgery world, and they listen to them, and then sometimes they do hear, who needs a stent? For a long time it was flap everything. Pin holes are for pin heads. You don't punch. and it's true. And it's like, for me, I teach the difference between a flap and a punch, and I think there's very appropriate applications for both. I really do. It's tough. I think, one of the things that is concerning, and I say this a lot, you get these people leaving for days on end out of their practices, leaving their families, spending buku dollars, going, wherever, whether it's in the country or out of the country, and they come back and they're still not ready, and I find that a crying shame personally. I really do. There's plenty to go around. If someone asks me about, some of the other implant education players, I'll always say, hey, I heard really good things about them. That's just my style, because I think that there's enough to go around. But the real discouraging thing for me is when someone comes to my class and says, I've been to seven courses and I can't get it together. And I'll say, well, what have you done? Well, I saw someone do an implant. No, that's not going to work. Or I worked on a dead person. That's not going to work. Or I worked on a pig jaw or a foam jaw. I'm like, listen, that's not how you did in dental school. Let's work on a real person. Like you did.
My first implant was placed on a research ape. It's called my ex mother-in-law, and that's
You're
what
the worst, man. I was told about you. I didn't believe it, but
I
it's true.
think. That's not why her daughter left me, but that I needed a good research chimp, and I thought she'd be perfect. Hey, let's get more specifics. Okay, your website is engelinstitute.com, right?
Sir.
What are your, first of all, specifics? I like to just help them make decisions, get her done. What are
Yeah.
your 6 locations, and exactly what are your 6 courses, and exactly what do they cost? Where are they? What do you teach? What does it cost?
Okay, so we are in. We've actually narrowed it down. I had 13 locations, and over the years, because of the notoriety of the program, people started traveling more, so I was able to go less places. Okay, so right now we are in Michigan, we are in North Carolina, we are in Houston, and we are in Arizona.
Where in Arizona?
We are in right near the stadium over there by Glendale.
But what's the facility?
So what we do is we do our first 2 days. It depends on what city we're going to, but typically we'll do our first 2 days in a very nice hotel, and then day 3 will be at a surgical facility.
So you do it at a periodontist office?
No, they're GPs. They're regular GPs.
So do you know my Arizona gig?
I do.
No, do you know for the hands-on surgical?
No.
Oh my God, this is so cool. You can do it. So if these dentists come out of state to Arizona and they go to this GP's office, they can't do the surgery themselves unless they're an Arizona licensed Western Regional Board, right?
It just depends on the body of who's teaching it.
Well, I'll tell you the gig going on now in Arizona and a couple other states have done it. So the homeless shelters for the vets have dental clinics, and there's one in downtown Phoenix. Chris Volchek runs it. It's Brightway for vets, and he went to the board and he says, if a licensed dentist in the United States comes to this dental facility and does implant surgery on vets, do they need a license? The answer is no. Some other guy heard about that, and then in New Jersey, he went to the board. So people are going around the United States and they're finding homeless shelter dental offices.
Yeah.
And the board is saying, so you get to treat a vet, a homeless person, someone, and so that's another gig. So you're in Michigan, North Carolina, Houston, and Arizona. That's the only. So you're down to 4 places.
And we're in Canada as well. So
Canada.
Yeah, we're in.
So is that mostly just for the treatment of hockey accidents, puck replacement teeth?
Puck replacements.
And you teach 6 courses, or is it?
So basically, we teach a mentoring 1, which is almost like I'll refer to it as algebra 1, where you come in, you get very strong didactics, and then we place an implant on a live patient, and we're in surgery all day long, and that culminates. Now M2 and M3 are like algebra 2 and algebra 3. Those are only done in North Carolina. I built a 7,500 square foot center there, and we do 501c3 dentistry. So just like the homeless shelters, but we do nonprofit for anybody in need, low income, Mothers Against Drunk Drivers, we churches, temples, we give it to everybody. And it's really incredible because this institute that I have has the classroom and the clinical setting in it. So basically, you're doing real life dentistry in a real life practice.
If I was you, what I would do, the best marketing you could do is film a course, the didactic part in your deal, put it on Dentaltown. Dentists around as an online CE, 1, 2, 3 hour, whatever. They'll meet your magic personality. They'll see your facility, and that'll make it easier for them to jump on an airplane and fly to North Carolina, and to see the state that makes you choke in the Super Bowl.
Yeah, maybe not. I don't know. What's interesting is you asked me about implants, and I know that we're coming down to the last 10 minutes, but if it's okay.
No, I'll go all night with you.
You know what? Okay, I'll keep it PG, Howard. But here's the thing. One of the things that we all know that Straumann and a couple other heavy players that have been around forever, they have a lot of very prestigious R&D. They're brilliant minds, you know. And one of the things that they wanted to do was Straumann, much like Nobel, who I was with for several years, Straumann wanted to break into the GP market, obviously, right? We're placing a hell of a lot of implants, and they are selling a lot of implants, right? So, hey, how do we do this? So I'm actually very proud to tell you that I'm the first GP in the U.S. doing a surgical program for Straumann. And what's really exciting is for all of these years, you know, you had this amazing, and they're still amazing. I've been to Switzerland twice in the last 7 months to go work with them. You have these brilliant minds, these mathematicians, these scientists that are developing, you know, threads and bones and, you know, and pitches and angulations and mechanics and engineering. Brilliant, right? Writing textbooks is what they do on the weekends for fun, right? And then they come to me and they say, okay, Engel, you know, how do we break into this U.S. GP market? And I say, you know what, you have to, in some aspects, we have to become more practical, meaning like give them a solid education, give them a very reliable product. For instance, right, if I was going to run in the Olympics, or you were going to run in the Olympics, and I said, Howard, because you asked me the implant question. So if you were going to run in the Olympics, I would say to you, Howard, what shoes are you going to wear? You're going to buy one of the 183 that are out there, or are you going to go with Nike or Adidas or Saucony, right? So it's the same kind of thing.
Asics.
Okay, fine. I buy that, and I like those shoes, actually. I wear them to work. But, you know, one of the things that Straumann had to do was make it practical for the GP, because let's face it, that's the domain that they want. So the president, who I'll leave nameless, is a very good friend of mine and incredible. He's in the position for the right reason. He said to me in his very thick...
You know Donald Trump?
Not that president. And I've got something else fun to tell you. But
oh, you're talking about the president, Straumann.
Sir.
Okay.
So, that was pretty funny, Howard. If I didn't know him, I wouldn't tell you. But anyway, he came up to me with this very thick accent, and he said, Todd, what makes you think that people can learn everything that there is to implantology in a weekend course? I said, I never said that. He said, well, how do you do everything in a weekend and send them back and they know everything? And I said, no, I've never said that they'll know everything. What I said was, we're going to give them a very good sound start. And then they'll go back, and I will guarantee that they'll place. Because in the classes, one of the things that I do that nobody else does is if you go to my class and you don't place, you come back for free.
Yeah, and how many molar root canals does an endodontist do in their 2-year endo specialty? How many?
Listen, why are the endodontists placing implants, Howard?
But you know, so many endodontists say, you know, you want to do molar endo, you send it in. Dude, you did 25 root canals, and there's dentists out there who have done 2 molars a day for 40 years. Don't keep parading on your plaque.
That's right.
Yeah. So it's a journey. I want to go back to specifics, dollars and cents. I'm a dentist, but I got an MBA from ASU too. 82% of American dentists take PPOs. And one of the things that's very profitable about these Medicaid, Medicare, PPO practices is they do a lot of stuff that's not covered. Like implants aren't covered. So you can go full fee. Invisalign is not covered. You can go full fee. When you talk about these socket grafts, or just your implantology, is everything you do off the PPO fee chart, or does insurance subsidize any of this stuff? If I started socket grafting my extraction sites, is anything billable to PPOs, Delta?
It's very touch and go now, you know, and the neat thing about socket grafting is it's a very good way to learn how to get surgically involved in a way that whatever you do, when it comes to socket grafting, unless you really beat it up, whatever you do, chances of you making it worse, Howard, before it started is almost nil. So it's really good, and I try to encourage, and I'm going to get to your question, I try to encourage GPs, if anything, get in there and treatment plan some socket grafts, because you know what? If it doesn't work, if the graft comes out or if the membrane comes out, it's not ideal, but the chances of it being worse than when you started are incredibly low. Now, you know, the insurance question, boy, that's across the board. You know what's interesting is in 1975, because you're a numbers guy and going to ASU for, what'd you do your degree in 14 years?
No,
Going to ASU and knowing the numbers, and you're a brilliant guy, and I know that. But what's really interesting, in 1975, right, when we were little guys, if 100 people went to the dentist and had one implant placed, 2 of those 100 people got $20 towards their implant. 98 of them got nothing. Today, we almost have 90% coverage by these insurance companies, and here's the reason why. Insurance companies are in business to keep your money. Would you agree?
right.
Insurance companies are in business to build big, beautiful mirrored buildings off the freeway so when you drive by, you can see the lizard at the top. That's how they do that. So they want to keep your money, not give it to you. So some letter room boy or girl, probably a girl because they're smarter, went up into the CEO at one of these insurance companies and said, guys, you have this all wrong. What do you mean? Well, if we cover implants, then we won't have to replace crowns on teeth in 5 years. You see, if you can get an implant to last a year or two, and it's got a nice crown on it, chances are it outlives the patient. So we get to keep our money. And guess what? For the dentists who are just average dentists who don't close their margins, it's not ideal, but a margin that's slightly open on titanium is far less crucial than a crown that's open on a tooth. You see, because if you have the Coca-Cola subscribers stay with the insurance company for 10 years and you do that 29 to 31 bridge, if 31's open, they're paying for the Coca-Cola guy to have another bridge. Now, by no means am I saying that any margin should be open, but what the insurance companies are realizing is that if you have less than ideal fit on titanium, they tend to last longer than less than ideal fit on a tooth. And again, they're taking the pragmatic approach. I don't agree with it. But so they're doing more. Okay, and here's the thing about grafting. It's one very gray area. Like sometimes they'll cover it and sometimes they won't. And you have to tell the patient. But, you know, unfortunately or fortunately, some of us are caught into diagnosing based on what insurance will do. I don't. I diagnose based on what I think will be best for the patient. And I think that that's where you become a wizard, when you really can explain, hey, guess what? The sinus is like a tent. And if you take out the tent poles of a tent when you're camping, what happens to the tent? It falls to the ground. So if I pull out this tooth and you have 3 roots that are the tent poles to the sinus, the sinus is going to fall, and it's going to lead to a number of other things. Howard, if the patient has the money, they're doing the graft.
You know, one time I wanted to do an allograft and I didn't have any, and I had to do a xenograft. I had a cow.
Hey, you're funny, man. That was a good one.
So how do you so what on grafting are you teaching? Autograft, allograft, xenograft, and what is, you know, and how much are you charging to graft an extraction site? Because wouldn't it be much cheaper if you grafted them all with an autograft as opposed to something else? Or what is your graft technique?
Yeah, depends on what you define as cheap. You see, when you talk about a autogenous graft, grabbing bone from the human in their own head, you know, you're looking at a lot of other things. You're looking at, you know, morbidity to the donor site, even more so than the recipient site. You're dealing with double the anatomy, double the pain. There's no question we know it's the golden standard for grafting. But the question is do we need the golden standard for everything we do? And I would argue no. I would argue emphatically no. Like if I was getting a hip replacement, use my stuff. Yeah, of course. If you're going in and you're getting, you know, something done on your knee, use your stuff. I get that. But when we're talking about salt and pepper around an implant, or we're talking about putting something into a socket that should turn over in 3 to 5, 6 months, if we know what we're using and why we're using it, then I'm all about an allograft. I'm all about the, you know, the same species, just not yours. And the reason for that is you have an abundance of it. You can buy it for $80 out of a box. You don't have to slice somebody open and take it from the maxillary tuberosity or the retromolar pad, have the patient call you that they're inflamed or, you know, need pain pills or whatever. So I'm a big fan of allograft, and the reason for that is because it's most predictable when it comes to socket grafting and growing new bone. It really is.
One of the problems I have with continuing education, you know, a lot of these big meetings, you know, they're always whining to me that their attendance has been going down. I think one of the reasons they don't realize their attendance going down is because millennials are fine with online CE. I mean, our online CE is crazy.
Yeah.
So they don't have to go to a brick building. But when you do go to these big meetings, I mean, the data shows that 96 out of 100 crowns are done one tooth at a time. And then you go to the big meetings, and all the courses are full mouth rehabs by prosthodontists. And you go to the room. How many of you have not done a full mouth rehab case this year? And 90% of the hands go up. Same thing with implants. You go into these big meetings, and the implant cases, you know, it's always these all on four, these full mouth rehabs. And most of the data I'm looking at is implants is like crown and bridge. They're mostly placed one at a time, but everybody that teaches it wants to teach a full mouth rehab. So getting back to my homies, these young millennials listening to podcasts under 30, are you going to focus on one at a time, or are you going to go in there and overwhelm them with rehab, prosthodontic, all on four?
You know, Howard, here's the thing. You know, my mom always taught me small bites. And you know, when I teach, my analogy is this. If you want to grow a field of sunflowers, if sunflowers are your favorite thing and you want to grow a field of sunflowers, you better learn how to grow one first. Soil, light, water. Where does one do best? Because if one goes down, you can try again, and you don't have a great loss. And once you've mastered where it should be, the soil it should be in, the light it should have, how many times a day or a week it should get watered, then run that beta and then do as many as you want. I will tell you this, that so to answer your question, it's one. And so, you know, people say, I see social media, and they say, well, why would you go do that when you can go do 50 in Mexico? Well, go do 50 in Mexico. I'm just saying, and I'm not saying that's bad. I'm really not. I'm honestly not. I'm saying, what do you want out of it? Do you want to say you did 50? I get people that come to the class and say, you know, I went somewhere and I did a bunch of implants, but I don't know the recipe. I don't know the protocol, where to stop, where to start. And so I send them home with a recipe. It's like a follow the yellow brick road, you know? And so for me, you start with one. Once you understand how blood works, how bone works, how implants work, what torque should be on an implant, how a patient should bite on an implant or not, should you stage it, should you do an immediate, why shouldn't you do an immediate? One, then you go and you do more. You know what's interesting is I completely know firsthand about what you're saying about these courses where, you know, one crown at a time. First of all, I feel that we're all the masters of our own domain, and I'm big on you do what's comfortable for you. You do what's comfortable for you. If you want to come watch me do an all on 4 and all on 6 just to see what it looks like, come on, stand by my side. But in terms of what I feel you should do, I feel you should stay in your comfort zone, and I think that you should be able to own your result and know where you're going. And that's one of the things that I start with at the day one of course one is I say, I'm going to teach you how to see what's at the end before you start. So going back to the big meetings, you know, just like articles, right? You get GPs that have placed 4 implants and then read an article and they want to do a guided all on 4. I see this all the time. Those are the ones that come in for help and repair. And what they don't understand and what I try to tell them is this. These people that are writing these articles, it's not their first rodeo, man. They've done this over and over and over and over again. And guess what? After that, they do it over and over again. And guess what? They get so good at it so that someone gives them remuneration to write an article, and they do. Now you read the article and you think you can do it. It's not good. You know, I remember 2 years ago, I did the very first live surgery for AGD in San Francisco at their annual meeting. They had like 4,000 people. And what's really interesting is they sold a ton of tickets to my course. So I was up there, I did a surgery, and it was like a very straightforward implant procedure, and the audience loved it and stuff, and the reviews were great. Right afterwards, they came in, the news interviewed me and said, okay, what can we do next year? And I said, well, why don't we do 2 days? I'll do 1 day of live surgery with implant stuff, and I'll do another day with socket grafting. But here's the moral of the story. Do you know that out of the 4,000 people, they sold a lot of tickets for people to come in? And what's really interesting is everyone stood at the back of the room. All in the back of the room. The first 12 rows were empty. Everyone was in the back. Or if you go to a meeting and you see they're standing looking in a booth. They just want to look in a booth and check it out. And as soon as the salesperson walks over, they bail, right? It's a level of commitment. So they want to see it, but they're not ready to dive in yet. And it's the same thing. Here's the biggest message I can give the GPs that are listening that are starting, right? It is a phenomenal profession. And if you apply yourself towards implantology or endo or whatever you want to do, I'll say implantology because I love it, right? If you apply yourself humbly to really learning and every day telling yourself, I still could be better, I still could be better, you know, it could be a phenomenal craft that could earn you a lot of money. And I'm okay with earning money as long as we do it for the right reasons, right? So to the young ones, be cautious, be humble, be disciplined. How do you do that? I guess you got to learn what it is that keeps you disciplined or not. Basics, man. We have periodontists, we have oral surgeons, we have endodontists come to my class. We just had an oral surgeon come to my class, and I said, you know, with all due respect to your knowledge, I have to ask you, in front of these people, and I knew the answer, what are you doing here? He said, you know, Engel, when we get too immune to things, we tend to lose track of the basics. He said, and so I'm here because I know that you teach the basics better than anyone. I want to learn the basics again. You know, and Howard, what I tell these guys is, I said, you know, it's like writing a great hit or a love song, Candle in the Wind or anything from our generation that's still playing, these Stevie Wonder songs or whatever, 30 years later, right? You listen to them and you go, man, why didn't I write that song? And we sing it in the radio, we sing it in the car, right? They're not easy songs to write, but they stick around forever. Point being, it's hard to stick with basics, but they're always going to keep you safe. And I swear to you, I do it every day. And that's what I teach, and that's why Monday morning they go back and do.
If I was going to write a love song, I'd name it "Do Not Resuscitate." Is that a love song? Back to the graft though. You're doing an allograft.
Yeah.
But what brand? What material?
So there's a company. So there's a half a dozen big tissue banks in the country that most of the companies get their products from and then relabel it, or they'll label it for these companies. One of the companies that I use is LifeNet. It's one of the biggest ones, and what they just have a patent on their processing. And I'm a D-min fan. I'm a D-min cortical bone fan, and there's a lot of reasons why. And we talk about this in the grafting courses, but I'll give it to you just so a couple little pearls to take home for the listeners.
It's liefmet.com.
LifeNet.
Oh, LifeNet.
Net.
Life. Okay, LightNet. LightNet. Okay. So
LifeNet.
Okay.
So I'm a D-min fan, demineralized bone fan, and they have a patent on how they process it. They'll acid wash it, and then they'll do a buffer solution. What's really interesting is that every time cadaver tissue is donated to this LifeNet bank, they actually run this computer analysis, and they actually create a program for that particular bone as to how much they wash it or buffer it or whatever to make the growth factors and platelets just really ready to rock in the graft. So it's pretty incredible.
And that website is actually lifenethealth.org.
Yeah.
Is that it?
The company, I apologize. You had asked the company. The company's called LifeNet.
The company's called LifeNet, LifeNet Health.
There you go.
Okay, just make sure. I want to ask you, we went over our hour, but I have some. Can I ask you a couple overtime questions?
I thought it was a 2-hour show, man.
It's can I ask you some overtime questions?
Of course.
Another big stressful thing. A lot of people are wondering if they should. When again, we're talking singles. We're talking. I want to talk about singles replacing a first molar. The first molar is the tooth most likely to be extracted, root canaled, crowned. It's all first molar dentistry for the most part for crown and bridge, endo implants. Would you cement that or screw it? Some people are saying that the number 1, 2, or 3 reason for an implant failure is excess cement. Some people are saying you want to be able to retrieve that. Some people are saying it's just a lot technically easier to do a cemented crown. Some people are saying your lab has to be at a whole nother level to screw. Are you a cementer or a screwer?
Yeah, that's a great question. And what's really interesting is, I'm going to answer it. Going back when I used to do world symposiums with Nobel, you'd have these guys and gals on stage that were the best of the best. You'd have audiences with their little remote vote tablets thing, and they'd be sitting in there, they'd be voting on which speaker they kind of believed in. And one of the topics every year was cementable versus screw retained. And it was always 48% to 52%. It never swayed beyond that. You can hear someone come up, this gal will come up for an hour and just blow you away with why things should be cemented. And then you'll get someone that 10 minutes later that will completely go in the opposite direction. So here's my feeling. I don't like to say always or never. I just don't. I don't say always or never because stuff happens. We know that. There's a bumper sticker that says that.
Okay, but I'll say always get a pre-month and never get married. But continue.
Okay. So my personal preference is cement. And the reason for that is a couple things. Number one, I teach to take x-rays every time you touch an implant. So every time you touch an implant, whether it's to take an impression or to put on a healing abutment or to try on a definitive abutment or cement, every time you do something, you take a 0.21 second x-ray, okay, to verify what you think you see. And I can tell you, I won't say never, but I can't remember the last time I had periimplantitis from cement. And the reason for it is I use a soft temporary cement because I use a lot of zirconia crowns on implants, and so it opaques it out. But my point is that this stuff is so radio opaque when it comes to an X-ray, you can click it off. Here's the other reason why. Because I have yet to be able to fill a screw hole to make it look like it never was there. And I think that when you're giving the patient a ha 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 smile, and you can see right down the occlusal planes of the lower teeth, my preference is to keep them virgin from the lab. Now, I completely feel that the people that believe that screw retained is the way to go, I back it. It's just like a religion. If you believe in that religion, God bless you, go for it. My religion just happens to be cement, but that doesn't mean screw retained is wrong. I do use screw retained in some circumstances, like geriatric patient, tough area to keep clean, can't keep it clean. So I do that too. But it really just depends on your preference. One of the things that I teach is to stay in the back of the mouth initially till you have 25 successful implants. And the cool thing about staying in the back of the mouth is the lab can help you make that decision. Hey, should it be screw retained or should it be cemented? Hey, Engel, I just got back this case and there's not a lot of room between the tissue and the opposing tooth. Why don't we do something screw retained and take away the cement line? And I say, yeah, cool, let's do it. Now, in the anterior, it's a little different because the placement is going to be a little different. So we're going to learn how to drive, for lack of a better way to explain it, we're going to learn how to drive in the posterior. And that's another reason why we've had some pretty good success.
By the way, when you say the guy said they asked you, hey, Engel, on Dentaltown, we have a search bar because 250,000 dentists have posted over 5 million times. And when you do a search for Engel, you just scroll down. You can scroll down for hours of threads talking about you, your course, your fans. I mean, it is amazing. And by the way, I hope you like that search function because that cost me $50,000 to put that.
I'm going to send you a check.
It cost me $50,000 to buy that Google search hardware, and you don't update the software. When you want to update it, you got to buy a new search thing for your deal. And it's every time we update that thing, it's $50,000. But you should go in there and search your name and read what all these people are saying for you. Last question. I know you're busy. You're out teaching. So you mentioned religion, and my sister, my 2 older sisters went straight into the Catholic nunnery right out of high school. My oldest sister called me today, and she said, are you going to go to Mass today and get ashes because today is Ash Wednesday? And I said, I would, but I'm podcast interviewing Dr. Engel during 5 o'clock Mass. So she's like, she's mad at you. She's probably putting a spell on you as we speak. But speaking of religion, I have friends that are ENTs and rhinologists, and this is how they talk to me. They say, look, dude, you're a dentist, so your sacred cow is teeth. And so you have a missing first molar. You got a tooth in front of it, a tooth behind it. Did you file the teeth down and do a bridge? Oh, hell no. You had to go into my sinus, do a sinus lift, pack all this cow bone and paper clips and crap. And they're saying that their practice is growing and growing and growing, and they're going into sinuses, and they're seeing these pervs and white candidiasis albicans all over the deal. In fact, this guy told me the other day, he says, I want to do a lecture on your course and just show you all the photos of these sinuses that have been jacked by implants. I'm like, dude, I would do anything for that course. So my question to you is this. I know you come from the high priest of odontology, but do you think if you were an ear, nose, and throat and you came from the rhinology sinus priesthood, that you'd say, you got a second bite in front of it, a second molar behind it, do a bridge. They've been doing them since the Egyptians 3,000 years ago. Do you think that since we're from the Church of Teeth, that we are going into sinuses way too many times, and that the 3-unit bridge is more moderate, faster, easier, cheaper, and this sinus lift stuff, we shouldn't be in there?
Well, I think coming from that perspective, I think it's a fair argument that we are going in too much. But I think it's just the same thing. Like if you have, let's say you have a huge periapical infection that just blows up over the weekend, you go to the hospital. What are they going to give you? They're going to give you Tylenol with codeine. They don't understand, just like we don't understand. They're not going to put you typically on an antibiotic and say it's a periapical infection. They're just going to give you something to get out of pain and go home. So I think someone who has expertise in their own field, I think would find good reason. I personally think that, one of the things that I dispel a lot is companies going out and saying, hey, if you buy this, this is the one drill that will do everything. BS. Or if you do this and you go into the sinus because of the shape and because of this, that, and the other, it's not going to perforate the sinus membrane. I don't believe that either. I think that there's a solid fundamental need to understand where you are and what you're doing, what you're feeling for, what are you looking for, what are some of the patient reactions and responses. So, the interesting thing about the sinus is it is very forgiving in that patients won't typically experience much with communication. All right, you can give them a Sudafed or an antibiotic and they're fine. But I would venture to say that if I was an ENT going in and seeing the aftermath, that I'd probably go, wow, what are these guys doing? But on the flip side, there's a lot of very talented specialists and GPs that are doing them correctly. So if it's me, like myself, a virgin number 3 and a virgin number 5, no, I don't want you to cut down my teeth. I want to go to somebody who's very capable. I want to sit in the chair and I want to have that done. But Howard, my decision process is really different. I'm a pretty practical, logical thinker. And I think that if you listen to anyone long enough, that you'll believe it. Much like Google, I always tell my patients, listen, don't be an internet Google, patient. You can find anything you want. You want to find something negative, you'll find it. I think that it goes back to this. So if an ENT guy says, hey, what are these kids doing in here? They have no idea what they're doing. They're taking a weekend class and bam, it could be true. It really could be. But then they're seeing the outside of it. It's kind of like, how many cats and dogs have you seen put to sleep? You ask the vet, it's a completely different story, right? It comes down to this. It comes down to, much like I've seen the stuff on Dentaltown about me. It was really funny. Last class, someone actually stood up and said, Engel, do you write this stuff? Because it's good. And I said, no, I don't write it. Here's my thing, Howard. I'm a very fortunate guy, and I say fortunate, not lucky, because I do work hard. And I work very hard at my craft. And here's the other thing. I wish others around me well. I like to see my students do well. If they go out and place more implants than me, great. I have a great family. I have a great life. I love what I do. And so my perspective in the world is different. I love teaching. I wake up, like I said, every day wanting to do it more and more. I'm on the road 105 days a year, now 106 with Las Vegas, and you better invite me because 161,000 dentists are listening. But
what is it? Where are you placing them in Vegas? Where's the location?
No. Well, Dentaltown, you already forgot.
No, I thought you have a hands-on course in Vegas.
No. I was going out once a month doing didactic lecturing for a weekend. But here's what it comes down to. Whether there's a lot of typically gentlemen that are in their 60s and 70s. Not so much gals because very few graduated at that time. But many are coming back to my class and say, okay, Engel, I've married off the kids. I've paid for the colleges. It's now my wife and I have plenty of money in the bank. I'm either going to stick around, revamp my office and do implants, or I'm going off to yonder. And Howard, every single time I heard one of the most emotional stories I've ever heard in Arizona at the end when they do their testimonials. It's a fun arena to play in. I love doing surgery. But it goes down to this, and this is what I want the viewers to know. you really have to understand your limitations. You have to care about the people that you're working on, and you have to provide them with an option for a result that you really can do. Be an expert diagnostician, and I'm good with closing there. What do they have? What are their options, and can you do it? Can you do it? Because that's what they're paying you $87 to do, to talk to them, right? So talk to them, and you say, Howard, you know what? You should have this sinus lift, and you should do A, B, and C, and D, but I'm not your guy. I think you should go down the street that does, to someone that's a little bit more qualified. So to the listener, you can make a ton of dough. You can love what you're doing if this is where you want to go. Just be cautious. I'll teach you. There's no question. Go to
and one last thing from that ENT guy. So I'll ask, any dentist, what is the number one tooth most likely to fail from a root canal? A maxillary first molar, because they missed the MB2. Yeah. And these ENTs and rhinologists say there's so many gazillions of Americans walking around thinking they have sinus allergies, thinking something's blooming, thinking they have an allergy. They're allergic to cats, and they've had a failing, leaking first maxillary molar for 5, 10, 20, 30 years. And that is the great thing about CBCTs. One of the questions you should ask on a health, if they got a maxillary first molar endo, you should ask them, how are your sinuses? Do you have allergies? Because so many of these allergies, in fact, he keeps one endodontist buddy of mine almost in full business, because when they do the CBCT on these chronic allergies, he said a failing, leaking endo is just routine.
Yeah, you could find them. Obviously, the technology is great. I could find them in PAs, a really nice, clean 90-degree angle PA. You could see them as well. But I think, again, that goes to who does that fall out on? Who does it fall out? Does it fall out on the person that missed the root canal, or does it fall out on the person who sees them 8 years later that just doesn't notice the lesion? I don't know. So I'm saying let's all just work a little harder at what we do and be better. We get on this little mice wheel. We go in at 8, we have our huddle, we see patients, we do composites and crowns, and then at 5:30 we go to the kids' baseball game, and then we go home and eat dinner and go to sleep, and every once in a while take a vacation. Whoa, figure out what you love. Figure out what you love. If you're doing endo just to make the production, figure out something that you love and transition. And go be really good at it. And go learn more every day. I read 6 days a week, Howard, because I want to be better. I want to do better for my peeps, It's a good life.
Well, thanks for coming on the show and talking to my homies today. I am your hugest fan. I hope you go on Dentaltown and do a search for your name, because you have so many raving fans. And if you're out there and just do it. I mean, just don't be paralysis by analysis. I mean, my God, if you can pull a first molar, you can replace it with an implant. And if you can't do that, and the only reason you want to do the white fluffy stuff is because you're scared. Learn how to be a bloody barbarian. Love extractions, love implants, love blood and guts. And when you say to me, well, I don't like blood and guts. Well, then why the hell did you become a doctor? You should have been an engineer. I mean, you're not working on an iPhone. You're working on a monkey. Thank you so much for coming on my show. God dang, you're amazing.
You look great.
Oh, thanks, man. You need to see an eye doctor. You need to get that prescriptions changed. And Zach, thank you for doing this tonight. It's after work. My son Zach is working late into the evening on this.